I'm just honored that Ann, Boston University Medical School, professor of neurology and pathology, Boston University, chief neuropathologist for the National VA ALS Brain Bank, director of neuropathology service for New England Veterans Administration Medical Centers. She's a chief neuropathologist for the VA Boston Healthcare System and director of Cte Center and Neuropathology Core for the Boston University's Alzheimer's Disease Center. Without any further ado, Ann, thank you for coming and giving us your latest on your research.
Oh, it's a pleasure to be here. So thank you, Kevin, and the organizers for allowing me to come and present at this very exciting conference. I thought your vision for the future was really terrific, and I want to be a part of it. We've done a lot of things at Boston University and the VA in Boston on a disease called CTE in the last 9 years, and I'm going to hope to right now share some of those discoveries with you. So I just want to first say that I have no disclosures. I very rigorously maintain no conflicts of interest because of the difficulties I have getting the word out without any conflicts. I don't want people to criticize the work because I have some vested interest. I don't. I'm going to talk about the Center for the Study of Traumatic Encephalopathy, which we started in 2008 with Chris Nowinski, Bob Stern, Bob Cantu, and myself. In 2014, it became the Cte Center. And over those 9 years since we started this center, we have published over 60 peer-reviewed original articles, and we just had 4 more accepted last week. And I'm just going to try to summarize what we've done in those years on the disease called CTE. So my first experience with CTE was actually in a boxer. It was a boxer who came to our Alzheimer's Disease Center with the diagnosis of Alzheimer's disease. But I was a neuropathologist who not only looked at all neurodegenerative disease, but I was particularly interested in the protein tau. I had been on several NIH consensus panels for tauopathies. And when I saw the brain of Paul Pender, who was a well-known boxer in this area, I saw the most extraordinary pattern of tau I'd ever seen in my life. And I knew it was nothing like any disease I'd ever seen before. It wasn't Alzheimer's disease. It wasn't PSP. It wasn't cortical basal degeneration. This was a truly unique disease. And that was my first experience with CTE. The 2 distinguishing features that I saw in that brain were the fact that the tau was around small blood vessels. It circled small blood vessels like a little bullseye. And it was also in the crevices of the brain. It was very patchy, but it seemed to prefer the crevices of the brain. Both of those features were something I'd never seen before, but I started to try to look at more boxers to try to understand this disease. And then I met Chris, and we started the Cte Center, and that was when we looked at the first 2 cases in NFL players. Both of those players were 45 when they died accidentally, and both of them, their wives had noticed some subtle changes beginning around age 40, difficulty with memory, difficulty with multitasking. They both died accidentally, Tom from an overdose, John from an accidental gunshot wound. And when we looked at their brains, and those are in the middle panel, you can see that even though they were only 45, they had the same disease as Paul Pender. It was that perivascular distribution of tau. And I think what was extraordinary for me at that moment was they were only 45 when they died. And I'd never in my entire career seen such severe neurodegenerative disease in such young people. And that was where we started, and we've gone a long way since then. We set up a brain bank so that we'd be able to harvest this tissue and understand the molecular basis of this neurodegeneration. We have over 450 brain donors at this point. And you can see from our experience, we've evaluated 400 brains. We have 284 with CTE. The large majority of the brain donors are former American football players, and we've had quite an extensive experience now with this disease. But it's not it's not just limited to boxers and football players. It's also ice hockey, soccer, rugby, professional wrestling, and very, very importantly, it's also military veterans, because exposure to blast and other concussive injuries during military-related activities is also a risk for CTE. So what is CTE? It's a progressive degenerative disease of the brain. It's found in athletes and veterans with a history of repetitive brain trauma. And that's not just concussions that we talk about all the time, but it's also those asymptomatic impacts, which we call subconcussions. CTE is defined by an abnormal deposition of tau in the brain, and it's in an extremely unique pattern. It's in a pattern in the brain that is distinctive from all other disorders. And currently, the diagnosis can only be made after death, but certainly, as one of the goals of this group in particular, we want to be able to diagnose this disease during life. We know that about 20% of individuals diagnosed with CTE never had any reported concussions. Our work has shown that CTE severity increases significantly with the duration of exposure, like the number of playing years, the higher your risk for CTE, and also the more severe CTE. And we know from the work of Bob Stern and others that cumulative head impact exposure, that is, the longer your playing career, it's significantly associated with more depression, executive dysfunction, apathy, and cognitive impairment. So how do we define CTE right now? By looking at it at postmortem. It is a pathognomonic tau lesion that I'm going to show you more about that's never found in normal controls. This has been shown repeatedly by multiple groups. It's never found in normal aging. I don't care what my detractors say, this is not normal aging. And it is certainly not found in any other neurodegenerative disease. So those diagnostic features are the fact that the tau in this disorder is distributed around small blood vessels in the initial stages of this disease. This is the distinguishing characteristic. And it's also deposited at what we call the depths of the sulci of the cortex. So that means the crevices of the brain. It tends to be deposited at the crevice of the cerebral cortex. We had a panel of expert neuropathologists gathered by the NINDS. And they, both times, the panel agreed that these features distinguish CTE from all other tau disorders, including Alzheimer's, PSP, our gyrophilic brain disease, primary age-related tauopathy. In fact, when we gave them 25 cases of other tauopathies with absolutely no clinical information, they correctly diagnosed CTE using these criteria 92% of the time, which was an extraordinarily successful result. What we know about the gross pathology of CTE is that it tends to only occur in more advanced stages. We don't see this in the young athletes with mild CTE, but in advanced stages, like in John Hilton and Lou Carpenter, you saw cerebral atrophy. You see changes of the cavum of the septum pellucidum, which is this membrane that divides the two hemispheres. You see something called a cavum septum pellucidum, or a space between the two leaflets that you don't see ordinarily. You also see atrophy of the medial temporal lobe, hippocampus, amygdala, areas important for memory and cognition. You see tremendous thalamic atrophy, dilatation of the ventricles. And in severe cases, you also see multiple changes in that septum. With all the fluid shifts of the CSF banging against the septum, we very commonly see fenestrations or holes in the septum. We might see multiple perforations. We might see the absence of the septum, all very common in late-stage CTE. We know that once the disease is triggered, it seems to progress even in the absence of more trauma. We know that most football players, if they're college players, stop playing at 25. If they're in the professional leagues, they usually stop before 40. But there is a progressive advancement of the pathology in individuals who die 40, 50, 60, 70, and I'll show you that in a minute. We also know their symptoms progress. When we talk to their families, this is a progressive decline in function. We did define the pathology into 4 stages, with one being the earliest, most mild disease. And you'll see it's just a single focus in the cortex, or multiple single foci in the cortex. So it's very mild in the early stages, but it's perivascular and at the crevices of the brain. And then in later stages, it spreads to involve other brain regions, and it becomes a brain-wide disorder affecting not just cortex, but medial temporal lobe, diencephalon, brainstem, and spinal cord. So this is just a montage of the stages of tau pathology. We found in our work that the stages or the severity of the pathology directly correlates with the number of years football players played. It also correlates with the age of the individual at death. And we think that the reason that tau is deposited in those particular regions around blood vessels and in the crevices relates to the physical forces experienced by the individual during football or other contact sports or military-related activities. That is, we know from the biomechanics that the forces are greatest at the depths of the sulci, at the crevices of the brain. The shearing forces are going to be greatest there. That's why tau is deposited there. We also know that the shearing forces are greatest at the junction between two different viscoelastic structures, like brain parenchyma and blood vessels. And so you're going to see the greatest tearing, the greatest shearing force in that area around the blood vessel, and that's exactly where the tau is distributed. We've also had, this is from a group in the UK, had nothing to do with our studies, but they did high-fidelity 3D computational modeling of helmeted head impact injury and found that it predicted very clearly the sulcal deposition of tau in CTE, that the forces of the injury were greatest in those areas where the tau is deposited. We know from Bob Stern's work that it has very commonly affects three clinical domains: behavior, there are behavioral changes, there are mood changes, often depression. Those domains are usually affected in individuals who present earlier in life, that is, in their 30s and 40s. They tend to have a behavioral mood presentation, whereas those who present later in life, 50s and 60s, it's often memory loss and cognitive impairment. It can look, for all the world, like Alzheimer's disease, and that these two presentations tend to converge as the person lives longer. The most common clinical symptoms that are experienced are listed here. Cognitively, it's memory loss, executive dysfunction, impaired attention. Behaviorally, it's violent behaviors, physical or verbal. Explosivity or short fuse, a minor infraction causes an exaggerated response. Personally, the thing that has always struck me is the loss of control. That's what I think a lot of these individuals complain out the most, that their head is, their thinking, their thoughts, they can't control their own mind. They're doing things they can't stop. They're behaving in ways they can't control. And that awareness of this brain disease is one of the most disabling features of the disorder. And then also there's mood changes, and it's often depression and hopelessness. So recently, we published the largest case series ever reported. It was by far the largest. It was well over twice any previous case series. And not only was this a case series of football players, not only was it CTE, but it was all football players. They'd all experienced a relatively homogeneous type of head injury. It was carried by the New York Times, and you can look at this montage and see that most of the individuals in this study had very severe disease with very high levels of pathology. We did find that of the 111 NFL players in the study, 110 had CTE, and often high-grade CTE. I think surprisingly, we also saw 91% of former college players in our study had CTE, 48 out of 53. And we even found some in players who only played at the high school level, 3 out of 14. Now, there's been a lot of discussion about this study and what it means. And I can tell you that it was not a population-based study, so it does not tell you what the prevalence of CTE is in the general population. It also was not representative of all football players because most of the individuals in this study played at a high level. But it did tell you that individuals who play football, particularly if they play high levels and for a long time, are much more likely to get CTE than those who do not. The denominator for the study is a little unclear. We don't know how many individuals who played football during the study period died. At least we don't know for high school players and college players. We do have some idea. This is a number given by Alan Schwartz. The number of former NFL players that died during the study years was 1,300. And if you assume that every single NFL player who died during the study period who did not donate their brain to our brain bank did not have CTE, which is a major assumption, assuming that no one that didn't come to me everyone was free of disease if they didn't come into my bank. That means that the prevalence of CTE amongst NFL players is 10%. That's the lowest it could possibly be. And so the question is that an acceptable risk for playing professional football? 10% coming down with CTE. Then the other issue that comes up with this study that's battered back and forth is selection bias. Yes, there's selection bias. A family that's concerned about an individual is much more likely to make a brain donation than a family who is not concerned. But you have to remember, these are ordinary people, regular citizens. They're not sophisticated diagnosticians. They're not medical professionals. They have no laboratory tests. They have no advanced technology to make a diagnosis. Yet all these regular families, 87% of the time, suspected CTE when it was present. And that is an extraordinarily high diagnostic accuracy rate, even for a tertiary medical center. So 87% of the people they suspected might have CTE had CTE. And these are regular citizens making this diagnosis. And the other factor I want to bring up is that selection bias is a factor for all brain banks. This is a brain bank based on exposure to head trauma. And in our other banks, that are also susceptible to selection bias, who do not recruit for head exposure, we see less than 5% with CTE. So it suggests that playing football and exposure to repetitive head trauma is significantly associated with CTE. Also, I think what's important about this study is not all of these were professional players. Some of these were amateur players, particularly college-level players, and we found even severe CTE in those groups. So this is a montage reflecting some of the 177 American football players in that study. The ones who died in their 20s and 30s are on the first row, and on the bottom row are the ones that died in their 80s. They're stratified by age at death. What I'm trying to show you here is no matter how you look at it, the earliest phases of CTE are these focal perivascular lesions in the cortex. That's what we see in all the individuals who die in their 20s and 30s. Yet as they live longer, the disease becomes more widespread. It starts involving other brain regions and affecting widespread areas. If you look at that more closely, the football players who die in their 20s, they have those focal deposits. But if they die in their 40s, you see a spread or enlargement of those focal deposits. And then you start to see involvement of the medial temporal lobe that you don't see in the earlier cases. Now, most people have retired from the sport in their 40s, yet we're still seeing a progressive change in the tau, even despite that. So that means that this is a disease that progresses. The tau spreads to other regions. It affects other brain cells, even in the absence of more trauma. This is a semi-quantitative plot just showing you the same thing. It starts out focally, it starts out in the cortex, and then as the person lives, they develop more widespread and more severe disease. So who is the face of CTE? You've heard about Lou Carpenter, you've heard about John Hilton, but I want to point out that these are young people, and that's what's really disturbing about this disease. It's young people playing football, ice hockey, soccer, rugby. It's military veterans. It's individuals who've died by suicide, individuals who've played in professional leagues. It's all demographics. Here's a couple examples. Eric Pelly, he died at the age of 18, and you can see those focal perivascular lesions of CTE in his frontal lobe. Here's another case. Owen Thomas played for the University of Pennsylvania. Again, CTE, those focal perivascular deposits in the frontal lobe. There's no way this pathology is normal or part of aging. This is CTE. This is Aaron Hernandez, 27 when he died, former NFL player for the Patriots. And you can see, even at the age of 27, he was showing severe changes in his septum pellucidum. You can see the fenestrations, or the holes in his septum pellucidum, and the enlargement of the ventricles with brain atrophy. Very severe disease, despite only being in his 20s. And here's what his brain looked like when we looked at it under the microscope. That tremendous cortical involvement affecting the frontal lobes. You can see widespread lesions throughout the frontal lobes. It was classic CTE. It was perivascular. It had all the hallmarks of CTE, and here it was advanced CTE, stage 3 in a 27-year-old. We've seen it in later stages in other individuals. I'm just going to show you one example, Dave Duerson, who died at the age of 50 with more widespread disease. So how can we detect CTE in living people, especially in the early stages? What should we concentrate on? Well, we need to figure out that initial CTE lesion, that perivascular tau lesion that we don't see in any other disorder. We know from our work at the VA and BU that it is a perivascular lesion that affects tau, but the tau is found primarily in nerve cells, but also affects astrocytes. We know that it's primarily around arterioles, not venules, that we find the perivascular lesion. And this is work of Russ Huber, who's starting to really dissect some of the microscopic features of this lesion. You can see the blood vessel location and the tau as neurofibrillary tangles. If we look at GFAP, we see reactive astrocytosis around that blood vessel, and we think that reactive astrocytosis, by affecting the end feet of the astrocyte, is part of the reason the blood-brain barrier shows leakage. And then we see, when we look for something like aquaporin, which is a marker of the lymphatic channels, it shows clearance around that vascular lesion. So this is just a montage showing the loss of aquaporin and the increase in reactive astrocytes. We know from the work of John Cherry, I know my time's out, that there's a lot of inflammation around those blood vessels, a lot of microglia. That microglial increase that we see occurs after repetitive head impacts, but then it becomes even more severe when CTE develops, and it becomes even more severe in severe CTE versus early CTE. So there's a persistent increase in inflammation, and we know from our work that this neuroinflammation promotes tau pathology, and the tau pathology further promotes inflammation, and it becomes a vicious feed-forward cascade. So the perivascular lesion of CTE very quickly is arterioles are damaged, loss of the blood-brain barrier, neurons around the vessels are damaged with neurofibrillary tangles, reactive astrocytes develop and further impair the blood-brain barrier. There's leakage of inflammatory cytokines and other molecules into the brain. There's microglial inflammation and tau accumulation and the loss of aquaporin. This is a recent report of ours in September where we reported a novel cytokine, an inflammatory cytokine called CCL11 that was increased in the brain tissue of individuals with CTE, even early CTE. There were 5 early CTE cases. They showed the similar elevation, and it was increased significantly different than the levels we saw in Alzheimer's disease and controls. And importantly, we also did looked at it in CSF. We didn't have as many samples, so it was only a trend, but we saw in the CSF, the spinal fluid, increases in CCL11 in CTE that we did not see in Alzheimer's disease or controls. We're looking at the spread of CTE. The biggest contenders for how spreads are that lymphatic channel dysfunction with impaired clearance, the trauma-induced blood-brain barrier breakdown and inflammation with promotion of tau, and then a vicious trauma-independent cascade. And we're also looking at prion templating of tau. We have one study with Stan Prusner's group who showed we were able to replicate the CTE prions in hex cells that express both 3R and 4R tau. So this is what we need to know. We need to know how to detect it in living people, especially in living early stages. We need to know how it spreads in the brain, even in the absence of trauma. We need to know the limits of head trauma, how many impacts are too many. We know there's most likely genetic susceptibility factors. We need to know more about what those are. We need to know if the time when you first start playing or first start being exposed to head trauma, is that important? We think it is. And what's the connection between CTE and other neurodegenerations like motor neuron disease, Alzheimer's, and Parkinson's? And then importantly, what are the treatments? So I think this is an urgent concern. Not only is it affecting the older players, but I'm seeing far too many individuals in their teenage years and in their 20s coming into our brain bank. It is very, very alarming. And I want to thank my group and all the individuals who've collaborated on this work, and thank my funding from the VA, NINDS, the Department of Defense, and historically the NFL, WWE, and NOCSI. Thank you.